Hello guys, I hope that you can hear me and that you can see the presentation. If there will be some difficulties, if you will not see the presentation, please let me know. Okay, so we will start. Today we will discuss the last topic. It will consist of two parts. First part will be about the embryonic development of the head and the face of the human embryo. And the second part will be about the histological structure of the organs of the oral cavity. So we will start with the first part, development of the head. Here you can see the process of the lateral folding of the embryo. You should be familiar with these pictures from the topic of the embryology. In these four pictures on the left, you can see the sagittal section of the embryo. So here is its cranial and here is its caudal part. And in these three pictures, you see the cross section of the embryo. So in all of these pictures, you can see the process of the lateral folding. This process happens both in the cephalocaudal and the lateral direction. It means that here, as you can see, the process goes as these arrows show. So the embryo, which is here in blue and yellow color, becomes covered with the amnion, and the yellowish endoderm becomes the embryonic endoderm, the primitive gut of the embryo, and the extra embryonic endoderm, the yolk sac. The same you see in these three pictures. Here the arrows show the lateral folding, and here you see the primitive gut, which is connected to the yolk sac. So the process of the lateral folding leads to formation of the primitive gut, and then this primitive gut is subdivided into foregut, the head region of the gut, midgut, the middle portion, and the hindgut, the last portion of the primitive gut of the embryo. Then, if we look at the frontal part of the embryo, here is its head. You see that at first the foregut, which is here, the head part of the gut, is not connected to the outer environment. So it is separated from the outer environment with the so-called oropharyngeal membrane. So this membrane separates the foregut from the outer environment. This membrane separates the primitive oral cavity, which is located here. It is called stomodeum. Then, in the fourth week of the embryonic development, the oropharyngeal membrane ruptures, it breaks, and so establishes the connection between the foregut and the oral cavity. This process you see in these two pictures also. This is the frontal view of the embryo before and after rupture of the oropharyngeal membrane. So here, as you can see, the connection between the oral cavity and the gut is established. And then, starting from week 4, the so-called pharyngeal apparatus develop. This pharyngeal apparatus is seen in the embryo. If you look at the embryo at this stage, so here is the head of the embryo, and these are the parts of the pharyngeal apparatus. Pharyngeal apparatus consists of pharyngeal arches, pharyngeal clefts, and pharyngeal pouches. Pharyngeal pouches are the outpocketings of the foregut. Here in yellow you see the gut of the embryo. Its frontal part is the foregut, and in next stage you see how the pharyngeal pouches grow from the foregut. So they are outpocketings of the foregut, of the endoderm. They grow from endoderm towards the surface of the embryo, and at the same time the pharyngeal clefts, invaginations of ectoderm, grow towards these pharyngeal pouches. And so, as a result, if we make the cut like this through the embryo, this is what we will see. Inside we see the gut. It is lined with endoderm, yellow in color. This endoderm makes the pharyngeal pouches, outpocketings that grow towards the surface of the embryo. So these are pharyngeal pouches. The ectoderm makes pharyngeal clefts, which grow towards the pharyngeal pouches. And so both pharyngeal clefts and pharyngeal pouches separate the parts of mesenchyme, which are called pharyngeal arches. So here is the pharyngeal arch. It consists of the mesenchyme, inside which we will find the blood vessels, nerves, and this mesenchyme contains both the migrating cells of the somites, the dermatome and myotome, and also the mesenchyme of the neural crest. So each pharyngeal arch, as you can see here and here, consists of the mesenchyme, and it is separated with the pharyngeal cleft and pharyngeal pouch. So inside every pharyngeal arch we see the nerve which grows from the neural crest and also blood vessels. Neural crest derived mesenchyme will make the skeletal components of the face, so neuromesenchyme will make the bone tissue, the cartilage tissue, and most of the connective tissue of the face of the embryo. And the mesoderm, the myotomes of somites, will give rise to the musculature of the face and the neck. So myotome will make the skeletal muscle of the face of the embryo. And these muscles will be innervated with their self-cranial nerves and accompanied with their own arteries. So arteries and nerves accompany each future muscle which is located in each pharyngeal arch. So here you can see how the pharyngeal apparatus develops in the embryo if we look at the embryo from outside. So here is the embryo at 25 days of development, 28 and 5 weeks of development. So as the result, the embryo will have 5 pairs of pharyngeal arches, 5 pairs of pharyngeal pouches, and 5 pairs of pharyngeal clefts. But most of them degenerate. So in 5 pairs of pharyngeal arches, the 5th is degenerating. Also, the 5th pair of pharyngeal pouch degenerate, and the pharyngeal clefts from 2nd to 4th also degenerate. So here you can see the pharyngeal apparatus, pharyngeal pouches, pharyngeal clefts, and pharyngeal arches. They are numerated like the first pharyngeal arch, second, third, and fourth. The Fifth pair is rudimentary. It means that it is not fully developed. Also, at the end of the fourth week, the first pair of branchial arches splits into the mandibular process, lower, and the upper maxillary process, or the same prominence. Mandibular prominence, lower one, and maxillary prominence. These prominences or processes will give rise to the structures of the lower and upper jaws, which are called mandibula and maxilla. And also we have in the upper part the frontonasal prominence. It is the rounded elevation of the cranial part of the embryo. So, as the result, if we look from the to the embryo um, as the frontal view, which is seen in this picture, we will see the stomodeum in the middle part, the primitive oral cavity, which is surrounded with frontonasal prominence, maxillary prominences, left and right, and mandibular prominences, also left and right. Lower, we see the pharyngeal arches, second and third ones. So these will be the structures of the future face of the embryo. Here you can see the structures which will develop from the pharyngeal arches. So first pharyngeal arch will split into the dorsal portion, the maxillary process, and the ventral portion, mandibular process. Mesenchyme of the maxillary process will give rise to the premaxilla and maxilla, not shown in this picture, but it should locate here in the upper jaw of the embryo. So also it will give the zygomatic bone and the part of the temporal bone. Mesenchyme of the mandibular process gives rise to the mandible, lower jaw, mechal cartilage, which is shown here as the black line, and the mechal cartilage partly makes the two of three bones of the middle ear, the malleus and the incus. Next, second pharyngeal arch will make the cartilage of the second hyoid arch, and also it gives rise to the third bone of the middle ear, the stapes, and also the styloid process of temporal bone, stylohyaloid ligament, and lesser horn and the upper part of the and the body of hyoid bone. The third pharyngeal arch, its cartilage will form the lower part of the body and the greater horn of the hyoid bone here. Fourth and sixth pharyngeal arches fuse together to form the thyroid, cricoid, arytenoid, corniculate, and cuneiform cartilage of the larynx. The fifth pharyngeal arch degenerates. It is rudimentary. So here in these pictures you see the derivatives of the pharyngeal arches. So here you can see the cartilage of the mandibular process of the first pharyngeal arch. Here the future maxilla develops also from the first pharyngeal arch. It is shown here, so maxilla and mandible develop both from the first pharyngeal arch, and the pharyngeal arches from the third to the sixth give rise to the bones and cartilage of the neck region of the embryo. Here we see the development of the pharyngeal pouches in details. So pharyngeal pouches are the outpocketings of the embryonic endoderm of the gut. So here is the gut of the embryo. The first pharyngeal pouch forms a stalk-like diverticulum outpocketing which grows towards the first pharyngeal cleft. and as a result, the first pharyngeal pouch will give rise to the structures of the middle ear, inside which the middle ear bones will be located, and the middle ear cavity will be connected to the pharynx with the auditory or Eustachian tube. So these are the structures which develop from the first pharyngeal pouch. The second pharyngeal pouch forms the bud, which grows towards the mesenchyme, and it will form the palatine tonsil. Tonsil is the large mass of the lymphoid tissue, which performs immune function. Next, third pharyngeal pouch has the upper and lower part, and it will give rise to the inferior, which means lower, parathyroid gland. So the upper part will give rise to the inferior parathyroid gland, and lower part will give rise to thymus. Parathyroid gland is the endocrine gland which produces the hormone which increases calcium level in blood. The thymus is the organ where T lymphocytes develop. So these structures develop from the third pharyngeal pouch. The fourth pharyngeal pouch, it also has upper and lower portion. So the upper portion will make the superior parathyroid gland, and lower portion will make the ultimobranchial body, which will be included to the uh, thyroid gland. Most of the thyroid gland develops from this area where the foramen cecum still is present after the part of the endoderm migrates from this region to form the thyroid gland. Pharyngeal clefts develop also from the week 5, so the first pharyngeal cleft will make the external auditory meatus, and it will cover the tympanic membrane or eardrum from outside. All other pharyngeal clefts degenerate. Here you can see the derivatives of the pharyngeal apparatus. So pharyngeal apparatus includes pharyngeal or branchial pouches, pharyngeal or branchial arches, and pharyngeal or branchial clefts. Pharyngeal pouch 1 gives rise to the middle ear cavity and Eustachian tube, which connects middle ear cavity to the pharynx. Pharyngeal pouch 2 gives rise to the palatine tonsil, which performs immune function. Pharyngeal pouches 3 and 4 gives rise to the parathyroid glands and thymus. Pharyngeal pouch 5 is rudimentary, it doesn't develop. Next, pharyngeal arch 1, first one, gives rise to maxilla and mandible, and also 2 of 3 bones of the middle ear, malleus and incus, and also chewing muscles and body of the tongue. Pharyngeal arch 2 gives rise to the hyoid bone, stapes, the third bone of the middle ear, and facial muscles. Pharyngeal arch 3 gives rise to the thyroid cartilage and root of the tongue. Pharyngeal arch 4 gives rise to the epiglottis, and pharyngeal arch 5 is rudimentary, it doesn't develop. Next, branchial or pharyngeal clefts, which are formed from endoderm. So develops only first of them, and it gives rise to the external auditory canal. The pharyngeal clefts from second to the fifth are rudimentary. They do not develop fully. And now we will discuss the development of face. The critical period for the face development is between weeks 4 and weeks 10 of the embryonic development. It is a critical period of orofacial development, and it means that if something bad happens to the pregnant woman or to the embryo in this period between weeks 4 and 10, it can affect the correct development of face exactly in this period between weeks 4 and 10. As I said previously, only the first pair of pharyngeal arch makes all the structures of the face. So, at first it splits into the mandibular and maxillary process, and then they give rise to the structures of the face. We will discuss it in the next slides in more details. So, here we see the stages of the development of the face. The first column of pictures shows the frontal view of the embryo's head and face, and this is the side view of the same embryo's face. Green color is for the frontonasal process or prominence. The yellow color is for the maxillary process or prominence, and blue color is for mandibular process or the prominence. So, at first, the primitive oral pit or stomadeum is surrounded with the unpaired single frontonasal process above and paired maxillary and mandibular processes. Left and right mandibular prominences grow towards the midline to fuse with each other, so left and right mandibular processes fuse together to form the lower jaw and lower lip. So at first, mandibular processes were paired like maxillary processes, but here you see their fusion, and here they form the lower jaw and lower lip of the embryo. Next, the nasal and lens placodes are formed. In this picture, you see the nasal placodes. Placodes means the thickening of the epithelium. So here will be future nostrils of embryo. The eyes are not seen in this picture. They are seen in this picture, in the side view. So here forms the lens placode. Lens placode will form the lens of the eye of the embryo. In this stage, the oropharyngeal membrane ruptures, disintegrate, and the communication between the foregut and the stomadeum is established. The next stage, you see that the frontonasal prominence is subdivided into the frontal proper process, this part, paired medial nasal, more dark green, here left and right, and the lateral nasal process, more yellowish green part, the lateral part, also in the left and the right. Here the same on the side view, the single frontal process, the lateral nasal process, and the medial nasal process. Between the lateral and medial nasal processes, the invagination, depression of epithelium is formed. It is called the nasal pit. It will be the future nostril of the nose of the embryo. In this picture, you see the eye that develop on the both sides of the head of the embryo. In the next stage, you see that the first pharyngeal cleft forms to form the external acoustic meatus in the neck region of the embryo. So here will the ear develop. So here you see the frontal process, medial nasal processes on the left and the right part, and lateral nasal processes also on the left and the right. Between medial and lateral nasal process, you see the nasal pit. It will be the nostril. Next stage. Lateral parts of the maxillary yellow and mandibular blue processes start to fuse together to form cheeks. So here will be the right and left cheek of the embryo. It forms as a result of the fusion of the maxillary and mandibular process in this area. It will be the cheek, and here also. The fusion of the maxillary process with the lateral nasal process in this area, fusion of the maxillary and lateral nasal process um, starts in this area, and here begins to form the upper jaw and lip. In next stage, you see that the medial nasal processes, left and right, migrate to the midline and start to fuse together. Medial, lateral nasal processes and maxillary processes start to fuse together to form the upper jaw and lip. So, the lower jaw and lip forms as a result of the fusion of the left and right mandibular processes together. The formation of the upper jaw and lip as the result of fusion of two maxillary processes, two lateral nasal processes, and two medial nasal processes together. The eyes now take their frontal position, so the eyes move from the sides of the head to the face region of the head, so they both are seen in the frontal view now. And in this stage also the primitive nasal and oral cavities connect with each other, not seen in these pictures. And in next stages, the fusion of the medial nasal processes together results in the formation of the so-called intermaxillary segment. This intermaxillary segment will form the middle portion of the upper jaw and lip, and also the primary palate. And also this part will form the mid portion of the nose of the embryo. The palatine processes of the maxillary prominence form the secondary palate not seen in these pictures. And the palate will separate the oral cavity from the nasal cavity. Ears also move from the neck region upwards to find their final position. Also, as you see here, the lateral nasal processes will form the lateral parts of the nose, and the maxillary processes fuse with lateral nasal processes in this region of the nasolacrimal groove, and also maxillary processes fuse with the medial nasal processes to form the mid portion of the upper lip. So if something fails, if a fusion of some processes fails, it will lead to the congenital orofacial malformations or clefts. The same in the other example of pictures. So here you see orange for maxillary process. It will form the upper part of the cheeks and the part of the upper jaw and lip. Lateral nasal processes will fuse with the maxillary processes in this region, and lateral nasal processes will form the wings or lateral sides of the nose. The medial nasal processes fuse together here to form the intermaxillary segment. So they both form intermaxillary segment. It will make the primary palate. It is inside the oral cavity, it is not seen here. Also, they form the mid portion of the lip, it is called philtrum of the lip. Also, they form the middle portion of the nose between nostrils, it is called columella. And they form the ridge of the nose, the mid portion of the nose. So, frontonasal process, green, is next subdivided into the frontal process. It will make the forehead of the embryo. Medial nasal process, paired left and right, and lateral nasal processes. Maxillary processes are seen here, and mandibular process forms the lower jaw. So here you see the derivatives of the prominences. So frontonasal prominence will make the forehead, the bridge of the nose, medial and lateral nasal prominences. Medial nasal prominence will make the bridge of the nose, the philtrum, the mid portion of the upper lip, the primary palate, not seen in this picture, and this primary palate will have the upper four incisors and associated jaw. So the primary four incisors develop from intermaxillary segment from medial nasal prominences. Later nasal prominence here will make the sides of the nose or the wings of the nose. Maxillary prominence makes the cheeks, the upper part of the cheeks, the lateral side of the upper lip, also not seen here, secondary palate, and also all other teeth of the upper jaw except four incisors. Four incisors develop from the medial nasal prominence. All other jaws develop from the maxillary prominence. Mandibular prominence gives rise to the lower lip and lower jaw, and also the mandibular portion of the cheeks. The same in this picture. So frontal process is the purple, lateral nasal processes are blue, they make the lateral sides of the nose, and the medial nasal processes are greenish. They fuse together to form the bridge, the columella, and intermaxillary segment, which makes the philtrum of the upper lip and the primary palate. Yellowish are the paired maxillary prominences that fuse both with lateral nasal prominences and medial nasal prominences to form the rest of the upper jaw, lip, and upper part of the cheek. And mandibular prominences left and right fuse together to form the lower jaw and lip and the mandibular portion of the cheek. Now we will discuss the development of the parts of the face in details. So, development of the lower lip and jaw is the result of fusion of the mandibular processes. Mandibular processes develop from the first pharyngeal arch. So, mesenchyme of the first pharyngeal arch in mandibular process makes the Meckel's cartilage. It is seen here in this picture. Meckel cartilage navigates, helps formation of the bones of the lower jaw via direct osteogenesis. So this cartilage is not included in the formation of the bone, so the formation of the bone is direct from the mesenchyme, and the Meckel cartilage just helps the correct formation of the bone in this part. The ventral part of the Meckel cartilage forms the horseshoe-shaped primordium of the future mandible and guide its early morphogenesis, and the other portion of the Meckel cartilage makes the two bones of the middle ear, malleus and incus. The congenital orofacial malformations of the lower lip and jaw include medial cleft, microgenia, and macrogenia. Medial cleft happens in two forms. Medial cleft of lower lip, seen here, is the result of incomplete fusion of right and left mandibular processes. And the second form is the median cleft of both lower lip and jaw, seen in this picture. So it is more bad case than this one. In this case, the jaw is fused, but lip has cleft, incomplete fusion. So it is the result of incomplete fusion of left and right medial mandibular prominences. Micro and macrogenia is the result of too small or too large lower jaw. So micro means too small lower jaw, and macro means too large lower jaw. Next, development of the upper jaw, lip, and nose. The upper jaw, lip, and nose develop as the result of fusion of paired maxillary processes, paired lateral nasal processes, and paired medial nasal processes. Its development starts from the week 5.5, week 6. So during this period of time, the maxillary prominences and medial nasal processes start to migrate towards the midline. The left and right medial nasal prominences fuse together to form the intermaxillary segment, which give rise to the mid portion of the upper jaw and upper lip, as well as the primary palate, which separates the nasal sacs from the oral cavity. The upper lip forms as a result of fusion of the medial nasal process with the maxillary process on both sides, left and right. The nasolacrimal groove forms where the lateral nasal processes fuses with maxillary processes in this area. These grooves, directed towards developing eyes, will give rise to the lacrimal sac with a nasolacrimal canal, which connects the medial angle of the eye with the nasal cavity. Through this nasolacrimal canal, tears can pass from the eye to the nasal cavity. The nose is formed both from the medial and lateral nasal prominences. The fusion of the medial nasal prominences will form the nasal dorsum, and the wings are formed from the lateral nasal processes. Congenital orofacial malformations during development of the upper jaw and lip include oblique facial clefts, which result from the failed fusion between the maxillary and the lateral nasal processes. The line of fusion is shown in red here. If these processes fail to fuse, we will form this oblique facial cleft, which connects the mouth with the eye. So the stomodio, future mouth, and the eye here. Nasolacrimal groove should be formed here, but if the fusion of maxillary process with lateral nasal process is incomplete, we will have the oblique facial cleft. Other congenital orofacial malformations in development of the upper jaw, lip, and nose include cleft lips. In these variants, medial cleft lip, lateral cleft lip, and bilateral cleft lip. Medial cleft lip results from the failed fusion of the medial nasal processes. So, left and right medial nasal processes fail to fuse together. And this what we will have as the result, the median cleft lip. Lateral cleft lip is the result of the failed unilateral fusion between the medial nasal and the maxillary process, shown in this red line. Unilateral means only on one side, on the left or right side. And this what we will see as the result. So the philtrum is the derivative of the medial nasal process, and the rest of the lip developed from the maxillary processes. And here was the area of their fusion. The fusion was complete on the right side, but incomplete on the left. So here we have the lateral cleft lip. And bilateral cleft lip is a result from failed bilateral fusion between the medial, nasal, and lateral prominences. So here the process is the same on the left and the right part. And also we can have the cleft lip and jaw is the result of the failed fusion of the medial nasal processes. So here is the result of the failed fusion of the medial nasal processes. So it's kind of the nose which splits into two parts, because each part of the nose developed from each medial nasal process. And also the primary palate and the mid portion of the lip also splits into two because of incomplete fusion in this region. Now, development of the palate. Palate starts to develop on the week 6, 7, and it has two parts, the primary palate and the secondary palate. So, the growing palatine or palatal processes of maxillary processes are shown in red color here, start to grow medially and form the palatine processes. These palatine processes will make the secondary palate, and the primary palate with 4 incisor teeth develop from the intermaxillary segment. Intermaxillary segment is the result of fusion of two medial nasal prominences. So this is how they look like. So this is the philtrum of future lips, and here the primary palate develops. Yellow color here is for the maxillary process. Maxillary process forms palatine processes left and right, which grow towards the midline to form the secondary palate. And the edges of the palatine processes should fuse together to form the midline of the future hard palate, which will separate the nasal cavity from the oral cavity. So the secondary palate will form the 2/3 of the definitive hard palate and also the soft palate. So this is the section of the developing embryo's head, the frontal section. So here you can see the palatine processes, left and right. They start to grow towards the midline. The oral cavity is seen here with the tongue. At first, the volume of oral cavity is too small, but then volume of oral cavity increases. The tongue goes downwards, and the palatine processes first grow downwards, then they um, start to grow towards the midline to fuse together in the end. So here you see the fusion of the lateral and medial, of the left and right palatine processes together. So here the palatine establishes that separates nasal cavity from the oral cavity. The same in these pictures below. You see how the intermaxillary segment forms the primary palate, and the maxillary process makes the lateral palatine processes, left and right, that grow towards the midline to start to fuse both with the primary palate in this line and together in this line. So first they fuse with the primary palate and then together with each other to form first the hard palate and then after it the soft palate. Here you can see development of the oral and nasal cavities. Oral cavity develops from stomodium. Nasal cavity develops from the nasal pits. Nasal pits grow into the nasal sacs. At first, nasal sacs are separated from the primitive primitive oral cavity with the oronasal membrane, which next ruptures, and the connection between the primitive nasal cavity and the oral cavity establishes, which you see in this picture. So here is the oral cavity and nasal cavity. They are not separated from each other. But then the hard and soft palate starts to develop, and finally hard and soft palate separate nasal cavity from the oral cavity. Congenital orofacial malformations during development of the palate include cleft palate. They can be in different cases a result of failed fusion between the left and right parts of the secondary palate, between the fusion of the secondary palate with the primary palate, and the failed fusion between the primary palate and the rest of the upper jaw formed with the maxillary process. So here you see the example of the cleft soft palate. So the soft palate is not fused together, but hard palate is fused. So it is the failed fusion between the left and right palatine processes together in the distal portion, in this part. In this example, you see the cleft soft and hard palate and also cleft jaw and cleft lip. So both soft and hard palate failed to fuse together, and also we see the cleft jaw and cleft lip. So it is the same which is shown in this picture. So both left and right palatine processes didn't fuse together, and also palatine processes didn't fuse to the intermaxillary process or the primary palate. So here also we have the failure of the fusion between the secondary and the primary palate in this region. And also we have the failed fusion between the intermaxillary segment, which makes the primary palate, with the rest of the upper jaw and lip, which is formed from the maxillary segment. So here is the result. Next, development of cheeks. Cheeks develop as a result of fusion of the lateral parts of the maxillary processes with lateral parts of the mandibular processes in this region. The fusion starts from the most lateral part of the embryo and goes towards the midline, both on the left and on the right side. As a result, cheeks are formed and the mouth opening becomes more narrow. The congenital orofacial malformations during development of the cheeks include macrostomia and microstomia. Macrostomia is too large mouth, so it is the failed fusion of the maxillary and mandibular process. So too large mouth gap is formed. Microstomia is the result of too excessive fusion between the maxillary and mandibular process, which results in too small mouth. Next, development of the tongue. It starts on the week 4, and embryonic sources of development of the tongue include tuberculum impar or median lingual tubercle, this part, or unpaired medial swelling of the branchial arch first. Next, two lateral lingual tubercles, they are paired. Next, copula lingua, here it is, and also myotomes of the occipital somites that migrate in this region to form the skeletal muscles of the tongue. So, starting from week 4, the unpaired tuberculum impar start to develop on the floor of the primitive oral cavity, and the adjacent foramen cecum gives rise to a small area of the lingual dorsum. Anterior to the unpaired medial lingual tubercle, the lateral lingual tubercles are formed. They merge, fuse together, and grow forward to form the dorsum and the tip of the tongue. The muscles develop from the myotomes of the somites, and also the lymphocytes migrate here to form the lingual tonsil. Congenital orofacial malformations during development of tongue include ankyloglossia, here is caused by shortening frenulum of the tongue. It is the result of the attachment, to excessive attachment of the ventral part of the tongue to the floor of the oral cavity, with this part which is called frenulum. And it results of immobility of tongue. Fissured tongue or split tongue, shown here, is the result of incomplete fusion of the lateral lingual tubercles. Incomplete fusion in this area. Accessory tongue results from the abnormal morphogenesis of the unpaired lingual tubercle. Macro and microglossia means too large or too small tongue because of increased or underdevelopment, developing tongue. Next, development of salivary glands which produce saliva the fluid which fills the oral cavity, moistures it, and helps the first stages of digestion. So saliva is produced by major or large salivary glands. They include parotid gland, submandibular gland, and sublingual gland. So three pairs of major salivary glands. They are located outside the oral cavity and are connected with oral cavity with their ducts. And also we have minor salivary glands which are located inside the lips, the palate, the tongue, and the cheeks of the oral cavity. So major salivary glands start to develop um, on week 5, 6 for parotid gland, up to 7, 8 weeks for sublingual gland, and minor salivary glands develop later. So development in all cases include the um, dividing proliferation of the epithelial cells, epithelium of the oral cavity. These proliferating cells migrate downwards to the mesenchyme and form first the ducts and then the secretory portions of the glands. Most of the orofacial malformations can be treated with surgery. So here you can see the result of surgery of the lateral cleft lip. So before and after surgery. Also for progenia, too large lower jaw, and after the surgery. And for cleft, soft and hard palate, before and after the surgery. So we discussed the first part, and now the second part of the last topic, the structure of the oral cavity. Oral cavity is the first part of the gastrointestinal tract. Gastrointestinal tract is the tube uh, which has four layers. Here you can see the structure of the wall of the gastrointestinal tract, and here you have the intestine given as an example. So the wall of gastrointestinal tract includes the innermost layer, which is called tunica mucosa, or just mucosa for short, and mucosa includes three sub-layers: the innermost epithelial layer, which is called in Latin lamina epithelia mucosae. Lamina epithelia mucosae. Next goes lamina propria mucosa. It is the underlying loose connective tissue, which is located just under the epithelium. And the lamina muscularis mucosae. It consists of smooth muscle tissue. So these are the three components of the tunica mucosa, or just mucosa. Next goes the second layer, which is called submucosa. It consists of loose fibrous connective tissue with a lot of large blood vessels, nerves, and in some cases glands can be located there. Next goes the third layer, which is called muscular layer, or in Latin muscularis externa. Usually it consists of two layers of muscles, inner circular and outer longitudinal layer of muscles. And the outermost layer is called tunica externa. It can be serosa or adventitia. The difference between serosa and adventitia is in the presence or absence of mesothelium. The organs of the gastrointestinal tract which are located inside the uh, abdominal cavity are covered with mesothelium, so they will have the serosa. The organs of gastrointestinal tract which are not in the abdominal cavity, like esophagus, They have no mesothelium in their covering. They have just loose connective tissue with blood and vessels, so they will have the adventitia as the tunica externa. The oral cavity is the first part of the gastrointestinal tract, but oral cavity has only mucosa in its structure, and mucosa of the oral cavity lacks muscularis mucosa. In some cases, we will have also the submucosa, which connects the mucosa to the underlying tissues, which can be muscle tissues or bones. So, oral cavity structures include the vestibulum. It is the space between lips and cheeks and the teeth and gums. So the space between the teeth and lips and cheeks is called the vestibulum. The oral cavity proper is the space between the teeth, the floor of the oral cavity, the hard and soft palate, and also the tongue is located in the oral cavity. It is connected to the floor of the oral cavity. Oral cavity is continuous with the pharynx, and oral cavity is separated from the nasal cavity with a hard and soft palate. So oral cavity includes lips, cheeks not seen here, gums or gingiva, hard palate and soft palate with uvula, tongue, teeth, and their supporting structures, periodontium, which includes alveolar processes, periodontal ligament, and also major and minor salivary glands and tonsils are included in the organs of the oral cavity. The oral cavity mucosa consists of three types of mucosa: masticatory, lining, and specialized mucosa. Masticatory mucosa means the mucosa for chewing, and this type of mucosa is found in gingiva, gums, and in the hard palate. This type of mucosa has keratinized epithelium because it is more resistant for mechanical stress during chewing than non-keratinized. And in some cases, we will have the parakeratinized stratified squamous epithelium in the masticatory mucosa. The lining mucosa covers the inner surface of the lips and the cheeks and the soft palate and the lower part of the tongue and the floor of the mouth oral cavity. So it is just the ordinary lining mucosa with stratified non-keratinized epithelium and underlying loose connective tissue of the lamina propria mucosa and submucosa. So these areas are not subject to high stress during chewing, so they can be covered with this lining mucosa. Lining mucosa has the submucosa. Submucosa is for mobility of mucosa. Submucosa contains loose connective tissue and it ensures mobility of mucosa. The areas with masticatory mucosa usually have no submucosa. Instead, in these areas, such as on gingiva, in gums, the masticatory mucosa is very firmly, very hard attached to the hard tissue, to the bone. Underlying lamina propria mucosa, it is the loose connective tissue below the epithelium. It consists of papillary layer of connective tissue and the lower reticular layer of more dense connective tissue. The papillary layer is for giving blood supply to epithelium, and for more firm attachment of epithelium to lower tissues. And the reticular layer of the lamina propria is for attachment of the mucosa to lower tissues, to bones or uh, to muscle tissues. So mm, the depth and the number of connective tissue papillae um, contribute to relative immobility of the masticatory mucosa and for more tight attachment of the epithelium to underlying tissues. In masticatory mucosa, where we have higher mechanical stress during chewing. So it protects from friction and shearing stress. At the midline of the hard palate, which is called palatine rough, the mucosa adheres firmly to underlying bone, um, and reticular layer of lamina propria mucosa contains usually thick bundles of collagen fibers, which go towards the periosteum of the bone or to the muscle layer in such areas such lips and cheeks to connect mucosa to underlying more hard tissues. So, oral cavity structures are lips, cheeks, hard and soft palate with uvula, tongue, teeth with periodontium, and also minor and major salivary glands and tonsils. There are only two layers in oral cavity, tunica mucosa with no tunica muscularis mucosa, only epithelium and lamina propria mucosa, and in some cases tunica submucosa. It is absent on the dorsal and the lateral surface of the tongue because tongue uh, is included in the chewing process and it is subject to the mechanical stress. Also, submucosa is absent on the gingiva, on gums, and in some parts of the hard palate, the rough and the margin part of the hard palate, which is closely to the teeth. So we have three types of mucosa: masticatory, which covers gums, hard palate, and partly the upper part of the tongue. It is has partly keratinized epithelium, and it is firmly attached to the underlying bone in the case of the hard palate, or to the muscle tissue in the case of the tongue. So it shows high mechanical strength and low permeability, and it participates in mechanical processing of food. Lining mucosa covers the cheeks and lips from inside, also bottom of the oral cavity, floor of the oral cavity, which is beneath the tongue, soft palate with uvula, and ventral surface of the tongue. It has non-keratinized epithelium. It usually has submucosa, and this is why it is flexible and very elastic, and it is more permeable to water and chemicals than other areas. So we have the sublingual route of administration of some medical drugs. It means that, for example, some drugs for heart attack, for example, can be placed in this area just below the tongue on the floor of the mouth, and these drugs can be dissolved very fast and very fast absorbed through this lining mucosa to multiple blood vessels. And this is why this route of the administration of heart drugs is the best way, because it allows very fast action of these medicines in the urgent cases, in the case of heart attack, for example. Specialized mucosa is the third type of mucosa. It covers the dorsolateral surface of the tongue. It is specialized because it is specialized for tasting, uh, because it includes the lingual papillae, which cover the dorsal and lateral surface of the tongue, and these papillae, some of them have the taste buds with receptor cells for taste sensation. So, masticatory mucosa covers the gums, the hard palate, and also the so-called linea alba of cheeks. You see it here. It is the mid portion of the cheek, and this area, this line corresponds to the area um, when the lower and upper teeth meet together in the chewing process. So during chewing process, this area is usually damaged with lower and upper teeth. So in this area we have more keratinized epithelium, and this is why it looks more white. Because more whitish means more keratinized. Keratinization is the way of protection of mucosa against mechanical stress. So in the area where we have higher mechanical stress, their epithelium will become more keratinized and more white in color. So this is what we see in this area of the linea alba of the cheeks. And also uh, this type of mucosa covers the so-called filiform papillae on the upper surface of the tongue. These filiform papillae, they are very small, but they are covered with keratinized epithelium, so they look more whitish. The gums are seen here. And epithelium in these areas can be stratified squamous keratinized or parakeratinized. And we have 3 degrees of keratinizations: parakeratosis, orthokeratosis, and hyperkeratosis. Parakeratosis, um, it means that we have the thin outer keratinized layer, but um, the cell nuclei are still present in the keratinized layer. So in this picture, in the left part, we have the parakeratinized epithelium. We have the keratinized layer, but we still see the flattened um, cell nuclei here. These cells are already dead, but they still have the nuclei. So it is called parakeratinized epithelium. Orthokeratinized epithelium is just the same as we have seen in skin. So it is just ortho means true keratinized epithelium with um, 4 or 5 layers, including stratum basal, stratum spinosum, stratum granulosum, which is absent in the parakeratinized epithelium, as you can see here. So stratum granulosum with keratohyalin granules in the cytoplasm of the cells. And next, stratum corneum with no cell nuclei seen here. So this is the true keratinized epithelium, which is called orthokeratinized. And also we can have the hyperkeratosis. Hyper means um, higher than normal. So it is too thick outer keratinized layer. Um, cells without nuclei are in this layer, and a well-developed granular layer or stratum granulosum. This hyperkeratinized epithelium can be present in the areas with mechanical stress and trauma, such as in this linea alba in the cheeks. Lining mucosa covers the most of the cheeks and the lips from inside. Also bottom the floor of the mouth cavity, this area below the tongue, the lower part of the tongue, and also the soft palate with uvula. Lining mucosa has stratified squamous non-keratinized epithelium, lamina propria mucosa, and usually submucosa. Submucosa, it is more mobile, elastic, and flexible. And also it is highly permeable to water and chemicals. So here you can see the histological picture of the ventral surface of the tongue with lining mucosa. So mucosa here consists of non-keratinized epithelium and lamina propria mucosa. Lamina muscularis mucosa is absent, and the lamina propria mucosa is continuous with no sharp border with submucosa. Submucosa is also loose connective tissue as the lamina propria mucosa, but in submucosa we can have very large blood vessels here. And submucosa connects mucosa to underlying skeletal muscle tissue in the tongue. The lining mucosa is usually more um, darkly pink-red because of blood capillaries which come very close to the surface of the epithelium. And the color of the mucosa can tell us about the patient if he has some diseases or some conditions, such as if he is frightened, then the blood capillaries will be closed and less blood will go into the blood capillaries, and so the color of the mucosa will be more pale. More intense red color may indicate inflammation, because more red means more blood in blood capillaries. It is the result of the action of the cells involved in inflammation processes such as basophils and mast cells, which release serotonin and other substances which increase permeability of blood capillaries and increase their diameter. So the result is that more blood comes into these blood capillaries, and more blood is seen through the epithelium, and the color of the mucosa becomes more intense red. Specialized mucosa covers the dorsolateral surface of the tongue, um, because this surface of the tongue is specialized for taste, sensation of taste. This oral mucosa has stratified squamous non-keratinized epithelium, which covers the papillae. The papillae include fungiform, filiform, foliate, and circumvallate papillae. Filiform papillae are not included in specialized mucosa. Instead, they are covered with keratinized epithelium and take part in mechanical processing of food. All other three types of papillae include in their structure the so-called taste buds. So in this picture you can see the foliate papillae, one papilla here, one papilla here, one papilla here, and in their side walls we have lighter areas shown here in higher magnification. These are taste buds. This is one taste bud with the sensory cells in their structure. Sensory cells have microvilli with receptors for chemical molecules. Chemical molecules should pass with saliva to the space between adjacent papillae and act upon receptors on the surface of receptory cells. And so the sensation of taste happens. This type of oral mucosa covers the dorsal part of the tongue, and it consists of epithelium and underlying lamina propria mucosa. No submucosa we have here, and also no lamina muscularis mucosa. Lamina propria mucosa connects mucosa to underlying muscle of the tongue. So here you have the pictures of the specialized mucosa. Here you have the picture of the foliate papillae, which cover the lateral surface of the tongue with taste buds, lighter areas seen in the lateral surface of each papilla. Here you see these taste buds on higher magnification. And here is another picture of the section of the tongue. In this picture we have the filiform and fungiform papillae. Filiform papillae are covered with keratinized epithelium with whitish stratum corneum. They are not for sensation of taste. They are for mechanical processing of food. And these are fungiform papillae. They have taste buds. Now we go to the hard palate. Hard palate separates the nasal cavity from the oral cavity. It develops from two sources, from primary palate, which develops from intermaxillary segment, and the secondary palate, which forms from the fusion of the lateral palatine processes, which grow from maxillary processes. So, hard palate has four zones. Anterior zone, it is called fatty zone, 1/3 of the length of the hard palate. Most of this part develops from the primary palate. Next goes the glandular zone. The third zone is called the rough of the hard palate. It is the line which results from the area of fusion of the palatine processes during development of the secondary palate. And fourth zone is called marginal zone. It is closely attached to the teeth of the upper jaw. So the hard palate is involved in chewing process, in mechanical processing of food, so it is covered with masticatory mucosa, but two zones, fatty zone and glandular zone, have submucosa, which is unusual for masticatory mucosa. So now we look to the histological structure of these zones. So here in this picture we can see the glandular posterior zone. It has mucosa, which contains the epithelium, which is the stratified keratinized epithelium with stratum corneum seen here, and lamina propria mucosa. And next goes the submucosa with a lot of secretory portions of the mucous salivary palatine glands located in submucosa. This is why this zone is called glandular zone. So it is located here. In submucosa, in glandular zone, we have glands, mucous glands. The fatty zone also has the submucosa, but there in submucosa we will have a lot of adipose tissue instead of glands. This is why this zone is called fatty zone, because of fat tissue, adipose tissue. So hard palate is called so, it is called hard because it has the hard bone in its core. And the bone is covered with two surfaces. One surface faces the nasal cavity, and this surface is called nasopharyngeal surface, and lower surface looks to the oral cavity, and it is called oropharyngeal surface. So what we have in the upper nasopharyngeal surface? Bone in the center. It is the most part of the hard palate, bone tissue, and here we have the mucosa, which is firmly attached to the bone. Mucosa contains epithelium and underlying lamina propria mucosa. Epithelium here, it is simple pseudostratified ciliated or respiratory epithelium, the same as we have seen in trachea. So This is simple epithelium, but the cell nuclei are located at different levels depending on degree of their differentiation. Here we have two cell types, ciliated cells and goblet cells. Goblet cells produce mucus, and then this mucus with attached bacteria and dust particles are this mucus is moved with the help of cilia of ciliated cells. In the lamina propria mucosa, we have loose connective tissue with a lot of blood vessels. Blood vessels, mostly capillaries and small venules, serve for conditioning of the inhaled air. It means that the air that we breathe in should be heated up to our body temperature and moistured. Um, Instead, our lungs will be damaged with too dry and cold air. So the blood vessels, which we see very multiple in the lamina propria mucosa, serve for um, heating and moisturing of the air. And mucosa is firmly attached to the bone. If we look now at the oropharyngeal surface, also we have here the part of the bone, and this surface has mucosa and submucosa, unlike nasopharyngeal surface where we have only mucosa, no submucosa. So back to oropharyngeal surface. Mucosa here contains stratified keratinized epithelium with stratum corneum seen here. Next, lamina propria mucosa has two sublayers, papillary layer with connective tissue papillae, which are very high and multiple, and this increases the attachment of epithelium to underlying connective tissue. So the more wavy surface of the attachment we have, the more tight attachment we have in the result. So papillary layer with high papillae, and next goes reticular layer with more dense connective tissue with a lot of thick bundles of collagen fibers. Then, with no clear border between lamina propria mucosa and submucosa, so then goes the submucosa, inside which we have here a lot of minor salivary glands and large blood vessels and nerves. Submucosa is connected to the bone. So this is the structure of the glandular part of the hard palate. It is glandular because it contains glands in submucosa. Next, we go to the soft palate. Soft palate is continuous with the hard palate, and it separates the oropharynx from nasopharynx. Unlike hard palate, soft palate has no bone. This is why it is called soft and not hard. In the core of the soft palate, we have the muscle tissue, which makes tendinomuscular layer. So here, this picture, we see the cross sections of the muscle fibers of skeletal muscle tissue, which makes the core layer of the soft palate. As the hard palate, the soft palate also has the nasal surface and oral surface. The nasal surface has only mucosa with no submucosa. Mucosa contains respiratory epithelium, ciliated pseudostratified epithelium, and lamina propria mucosa with a lot of mixed glands which produce mostly mucus, and also lymphoid follicles with lymphoid tissue. Then we go to the oral surface. As in the hard palate, in soft palate we have in the oral surface mucosa and submucosa. Mucosa contains the non-keratinized stratified squamous epithelium, lamina propria mucosa, which makes the papillae here, and then we have the submucosa with a lot of mucous glands and adipose tissue. Here we see the histological section of the soft palate. So here is the nasal surface in the upper part, and in the lower we have the anterior or oral surface. The same on high magnification. So here we have the portion of the nasal surface with the mucosa, which contains epithelium and lamina propria mucosa with secretory portions of mixed and mucous glands. And also here we see some cross-sections of muscle fibers, which are located lower, but some of them come between the secretory portions of the mucous glands. In the lower picture, we see the portion of the anterior surface. It has the mucosa with the non-keratinized stratified epithelium, lamina propria mucosa, and next goes the submucosa with glands, and submucosa is connected to the striated muscle fibers of the tendinomuscular layer. Another example of the same structure, the histological section of the soft palate with the nasopharyngeal surface in the upper part and the oral surface on the lower part. So we see on the nasal surface ciliated epithelium, lamina propria mucosa with some secretory portions of the mixed glands, and next goes the tendinomuscular layer with sections of the muscle fibers. Some secretory portions of the glands are located at the same level as the sections of the muscle fibers. In the oral surface, we have the submucosa with also some secretory portions of the glands, and with no sharp border, submucosa goes to the lamina propria mucosa and next stratified non-keratinized epithelium. Next we go to the lip. So here is the cross section of a lip. The lip in the cross section has three zones. The skin zone here, it looks like the skin, it is the outermost surface. Next, transitional zone, it is here, transitional zone or vermilion, it is the reddish part of the lip. This part upon which the lipstick we use. And the third part is the mucous part or mucous zone. It is the most innermost zone which faces the teeth, mucous zone. In the center, in the core of the lip, we have the skeletal muscles. This muscle is called orbicularis oris muscle. So here we see the bundles of cross-sected muscle fibers. Now, skin zone. This part, it contains epidermis, which is stratified squamous keratinized epithelium, and dermis. Dermis contains papillary layer of loose fibrous connective tissue, which makes very small papillae. Reticular layer contains dense fibrous irregular connective tissue with a lot of nerves, blood vessels, also hair, which you can see here, the hair, sebaceous glands, which are associated with hair, and also sweat glands, and some amount of adipose tissue. The dermis of the skin zone is connected to the muscles of the lip. Next, transitional zone or vermilion or intermediate zone. It is the intermediate zone between the skin and mucous zone. So here in this transitional zone, the stratified squamous keratinized epithelium of skin turns into stratified squamous non-keratinized epithelium of the mucosa part. In this epithelium, if we look at this picture, the thickness of epithelium increases. If you compare the thickness of epithelium in this part and in this part, so it is larger increases, but the thickness of stratum corneum decreases when we go from the skin part towards the mucous part. Next, the dermis of the skin in transitional zone turns into lamina propria mucosa and submucosa of the next mucosal zone. The papillae of the papillary layer of the dermis of the skin in this transitional area, these papillae become more higher and more multiple. So papillae in skin zone are very small, and papillae in intermediate zone become much higher, and the blood vessels go into these papillae, and these blood vessels so are located very close to the surface of epithelium, and so we see the blood and blood vessels in these papillae, so this zone seems very red in color because of blood vessels and a very thin stratum corneum in this area. The hair and sweat glands in transitional zone disappear, but some sebaceous glands remain, especially in the corners of the mouth and on the upper lip. But in the lower lip, the sebaceous glands, which produce lipids, are almost absent. This is why the lower lip usually becomes very dry, and it can crack. The epithelium can be damaged and cracked, and this is why we need to moisture our lower lip with the help of our tongue with saliva, or to use special lipsticks to apply this lipstick to our lips, especially on the lower one, because it has no sebaceous gland in its structure. Also, this part, transitional zone of lip, has very high density of sensitive nerve endings. So this is why lips are very sensitive area of our body, and this helps babies when they look at the outer world, and they try to sense all the subjects using their lips and tongues. And finally, mucous zone, innermost part of the lip. It has mucosa and submucosa in its structure. Mucosa contains stratified squamous non-keratinized epithelium or partly keratinized in the areas of high mechanical stress during chewing, underlying lamina propria mucosa, which makes very high papillae. Blood vessels in these high papillae make very red color of the mucous zone of the lip. Submucosa has large blood vessels, nerves, adipose tissues, tissue lobules, secretory portions of the labial glands, the glands of the lip. These glands are complex branched alveolar tubal glands. Most of them are mucous. Also, submucosa contains bundles of collagen fibers that go directly from mucosa towards the muscle layer, to the muscles of the lip, and thus very tightly attach the mucosa to the muscle, and it prevents forming of folds during chewing, so it prevents biting of lips during chewing, because the mucosa is connected to the muscles. Here you see the histology of the lip. So here is the skin portion, transitional zone, and mucosal zone. Here you see the structure of the skin or cutaneous zone, the structure of epithelium, which is the keratinized epithelium with stratum granulosum and stratum corneum, and very small papillae. Next, we go to the transitional zone near the skin zone, number 2, and transitional zone near mucous zone, number 3. In transitional zone near the skin zone, we have increasing thickness of epithelium and decreasing thickness of the stratum corneum, but stratum granulosum is still present. And also we have here much higher papillae, which go almost to the surface of epithelium. So they come very close to epithelium, to the surface of epithelium. In the part of transitional zone near the mucous one, we have very high papillae, very thick epithelium, and epithelium changes from auto-keratinized to para-keratinized with no stratum granulosum and cell nuclei present in the stratum corneum, and this para-keratinized epithelium will go next to the non-keratinized epithelium of the mucous part of the lip. Another example of the section of the lip, this is the skin part of the lip. It has epithelium, epidermis, dermis, which contains papillary layer with papillae, and reticular layer with dense fibrous connective tissue. Here we see the hair with associated sebaceous glands and also sweat glands. Another example of the lip microanatomy. So in the middle of the lip we have the muscle layer with striated muscle tissue of muscle fibers. Cutaneous or skin part has the epidermis and dermis with hair, sebaceous glands and sweat glands. Mucous part has the mucosa, which contains partly keratinized or non-keratinized stratified epithelium and lamina propria mucosa, and then goes submucosa with a lot of secretory portions of the mixed salivary glands of the lip or labial salivary glands and lobules of adipose tissue. Submucosa is connected to the muscular layer with the help of thick bundles of collagen fibers which go from the lamina propria mucosa directly towards the muscular layer. Next, gingiva or gums. Gingiva or gums have 3 parts. Attached gingiva, here it is, attached gingiva. Next, free or not attached gingiva or marginal, it is here, attached gingiva, and interdental gingiva. Inter means between, dental means teeth. So these triangular in shape parts of gingiva between teeth are called interdental gingiva. The gingiva is continuous with the alveolar mucosa of the lining type, which covers the alveolar processes of the jaws. Gingival mucosa is the mucosa of masticatory type, because the gingiva participate in the chewing process, in the mechanical processing of food, so they should resist mechanical stress. Lamina propria contains papillary layer with high papillae and reticular layer with thick collagen fibers which attach epithelium to the alveolar bone. In this picture we see the structure of attached gingiva. It is called so because it is attached to the alveolar process of the bone. So here you see the direction of collagen fibers which attach the attached gingiva to the periosteum of the alveolar bone. Free gingiva is shown here. The border between the free gingiva and attached gingiva is the gingival groove. Attached gingiva includes stratified squamous partially keratinized epithelium and lamina propria mucosa. It has thick bundles of collagen fibers. Free gingiva also has stratified squamous partly keratinized epithelium and lamina propria with bundles of collagen fibers which go in different directions, attaching the free gingiva both to the tooth and to the alveolar bone. The, here we have the space between the tooth, this is the enamel of the tooth, and the free gingiva tip or margin. So this space between the free gingiva and the tooth is called the sulcus. Sulcus. It separates free gingiva from the tooth. This epithelium, which lines the sulcus, is called sulcular epithelium. It is stratified squamous non-keratinized, unlike the epithelium of free and attached gingiva, which is keratinized or partially keratinized. And also we have the junctional epithelium. It is in this area. One surface of this epithelium faces the lamina propria mucosa, and second surface is firmly attached to the enamel of the tooth in this area. So junctional epithelium is between the lamina propria of the gingiva and the enamel of the tooth, or the cementum of the tooth. The chemical structure resembling basal lamina is secreted with the cells of junctional epithelium and covers the enamel or the cementum of the tooth. And the cells of the junctional epithelium can attach to this material with the help of hemidesmosomes. Hemidesmosomes are the junctions which help to attach the cell to the underlying extracellular matrix. So the basal lamina and hemidesmosomes together are referred to as the epithelial attachment. Also we have the term periodontium. This term includes all the tissues involved in attachment of the tooth to the mandible or maxillary bone. So these tissues include the sulcular epithelium, the junctional epithelium, also cementum, periodontium, and alveolar bone. So these all structures together form periodontium. Here we see the histological section of the gingiva. What do we see here? This is the decalcificated specimen. It means that all the minerals were dissolved. So during decalcification, all enamel of tooth was dissolved. So here, number 6 is the area where the enamel was present before decalcification. Below enamel we see the dentin. Dentin is here. In this area it is covered with the cementum. This is the free gingiva. This is the gingival groove which separates free gingiva from attachment gingiva. So attachment gingiva has the epithelium and lamina propria mucosa, which attaches gingiva to the alveolar bone. Epithelium is stratified keratinized here, and the lamina propria mucosa forms very high and multiple papillae, which increase attachment of epithelium to underlying connective tissue. Connective tissue here has a lot of thick bundles of collagen fibers which go from epithelium to the bone to attach the gingiva to the bone. The same structure is in the free gingiva with the keratinized epithelium and very high papillae of connective tissue. Next goes the sulcular epithelium. Here it is. It lines the sulcus, the space between the gingiva and the enamel. Sulcular epithelium is non-keratinized. This is the junctional epithelium. So one surface faces the enamel, second surface faces the underlying connective tissue, junctional epithelium. Here we see the portion of the section of the gingiva. You see here the keratinized epithelium with stratum corneum where no cell nuclei are seen. And lamina propria makes very high papillae for strong attachment of epithelium. Next we go to the cheeks. The cheek has the outer or skin surface and the inner or the mucous surface. Both of them, if we make the section like this, have the upper part, the maxillary zone. It corresponds to the maxilla, upper jaw, and mandibular zone, lower part, which corresponds to mandibula. The line between corresponds to the linea alba, and actually it is the line of fusion between the maxillary process with mandibular process during embryonic development of the embryo. So if we make the section, we will see that in the center of the cheek we have the skeletal muscles. So this is the core of the section. Buccal muscle or the muscle of the cheek. Also here in this part we can have the glands, buccal or salivary glands of the cheek. They are mixed, mainly mucous glands. In the mucous surface we have the mucosa and submucosa. Mucosa contains stratified keratinized epithelium, non-keratinized epithelium and lamina propria mucosa. In submucosa, we have the buccal salivary glands and some amount of adipose tissue. If we look to skin surface, we have here, just in all other parts of our body where we have skin, we have epidermis with stratified keratinized epithelium and dermis, which contains papillary layer of loose fibrous connective tissue and reticular layer of dermis with dense fibrous irregular connective tissue. And also we see here hair, associated sebaceous glands, and sweat glands. The reticular layer of dermis is connected to the buccal muscle, as the submucosa of the mucous surface also is connected to the buccal muscle with the help of the very thick bundles of collagen fibers which go from the lamina propria mucosa directly towards the muscle layer. And this prevents formation of folds of the mucous surface during chewing, because the folds can be bitten during chewing, and thus the mucous surface could be damaged. But the connection of epithelium to the buccal muscle with thick bundles of collagen fibers prevents damaging of the mucous surface during chewing. And also some examples of this histological preparation. So this is all. Thank you for your attention. See you in class. Goodbye.